Okay, good afternoon, everyone. Thank you for joining us today for the MVC's first work group of 2023, and as well as our first Health and Action work group of 2023. In honor of the Healthy Weight Awareness Month of January, today's session will feature a presentation by Dr. Oliver Varban of the Michigan Bariatric Surgery Collaborative, also known as MBSC. Today's presentation will be on the burden and challenge of treatment and how MBSC uses data to improve surgical management outcomes. A little bit of background about Dr. Varban. He is a minimally invasive surgeon who specializes in bariatric surgery and has been in practice since 2010. After graduating with a degree in molecular biology and genetics at the University of Pennsylvania, Dr. Varban completed his medical school and general surgery residency training at Wake Forest University. Afterwards, he completed a fellowship in minimally invasive and bariatric surgery at Brigham and Women's Hospital. Dr. Varban has previously served as the president of the Michigan State chapter of the American Society of Metabolic and Bariatric Surgery, or ASMBS, and currently serves on the executive board of the Michigan Bariatric Surgery Collaborative, as well as on the ASMBS Committee for Quality Improvement and Patient Safety, and the editorial board of surgery for obesity and related diseases, also known as SWORD. He has published numerous research publications featured in the New York Times and presented both nationally and internationally on the topic of obesity, metabolic syndrome, and outcomes with bariatric surgery. Thank you again, Dr. Varban, for joining us today at the MVC. You are welcome to share your presentation. After I continue these few slides, I just wanted to do some quick housekeeping. We are recording today's session. The slides and recording will be shared after the conclusion of the work group. We will be monitoring questions throughout the work group. So if you have any questions, feel free to put them in the chat. Also save them for afterwards in the discussion. And then we will have a post work group survey that will be sent out with the email with the slides and everything. So please just take a few minutes. It's only a couple questions to provide feedback on today's work group. All right, and on that note, I'm going to hand it over to you, Dr. Varban, and the floor is yours.
Okay, thank you. Can everybody see those slides all right?
Looks great.
Awesome. Well, thanks so much for the invitation today to be a part of this forum. As you know, that I'm a bariatric surgeon, so I have a lot of passion for treating obesity and studying it. And I think this topic is timely, right, for this month, this Healthy Weight Awareness Month. So I look forward to questions and discussions after this talk. Okay. So I'm going to move this here just so I can see my screen a little bit better. Awesome. So I don't have any disclosures, but as you've heard, I am a bariatric surgeon. I have been involved in the Michigan Bariatric Surgery Collaborative since essentially when I started practice. And so I will take the opportunity to share with you some data from our collaborative, in the context of obesity care. All right, so I've structured this talk around the challenges of treating obesity, and there are many. But I'm going to focus on three specific ones, and I think it'll provide us the opportunity to talk about, to leverage what we do in our respective collaboratives to make an impact. All right, so the first challenge is that obesity, as you probably know, is pervasive, it's complex, it's multifaceted. So how bad is it? Well, if you look at the most current sort of heat map of the prevalence of obesity in the United States in 2021, the areas that you see that are in orange or brown or in red are higher levels of obesity. So these are rates of above 30%. And this is pretty sobering considering back 10 years ago, this was not the case. So certainly the prevalence of obesity has increased significantly over the last 10 years. If you look both at obesity alone, which the CDC categorizes as a body mass index of 30, as well as severe obesity, which is categorized as a body mass index of above 40, that's up to 9.2%. And as you can see, the prevalence of this is not uniform. There's a lot of heterogeneity between sex, ethnicity, and race. So how's Michigan doing? So it ranks 16th at this point in time. So there are 35% of people within or in Michigan who have a body mass index of 30 or above. So why is it a problem? Well, it is a problem because obesity literally impacts every organ system in the body, and it's associated with a lot of different conditions. And it's also associated with cancers. And if you can see there, 7.8% of all cancers are associated, or excess body weight is associated with 7.8% of all cancers. And some of them are pretty darn high, 60% of uterine cancers, 33% of liver cancers. So this is well beyond, the common comorbidities of diabetes, hypertension, hyperlipidemia. There's some other more sort of interesting topics that come around obesity and its impact on comorbidities, particularly with liver disease. The idea of fatty liver disease and its development into non-alcoholic steatohepatitis, also known as NASH, is one of the leading trends for reasons for getting a liver transplant. And not only is obesity bad because it gives you an increased risk of different comorbid conditions, it also increases the severity and the mortality when you do get another condition. So we learned that the hard way during COVID, when the majority of patients who had severe disease and mortality were people who were obese. So what are the treatment options that we have at this point in time for obesity? As clinicians, what do we offer our patients? Well, this is a document from the Michigan Quality Improvement Consortium. So this is what we use in the state of Michigan as a guideline for management of overweight and obesity in adults in Michigan. So as you can see, it starts off up here with screening and lifestyle interventions when the body mass index is above 25, which is considered overweight. As you move on to the body mass index above 30, this is where you start to introduce, in addition to lifestyle modifications, medication management, both in medications that treat obesity, that promote weight loss, but also investigating and evaluating current medications that promote weight gain. There are over 300 medications that we use now that promote weight gain, and many of them, unfortunately, are the same medications that we're trying to treat the comorbid conditions, things like insulin, things like treatments for depression and anxiety. So there's a lot there to unpack when it comes to being able to treat patients with medications, both taking some off and starting some new ones. As you see, all the way down here is surgery. This is indicated for patients with a body mass index over 40 or over 35 with comorbid conditions. All right, so with all of these possible interventions on hand, I think as clinicians, what we're trying to offer patients is identifying what are the risks and benefits of any one of those interventions, what is the appropriate timing of any one of those interventions, and it's on us to navigate our patients to the right treatments at the right time so they have the optimal impact. Well, unfortunately, this is what it looks like for obesity nowadays. It is very complex and it's not uniform, and there's a lot of variation there. And sort of understanding how practice patterns affects outcomes, I think, is a very important but very complicated thing to try to pinpoint. And so this is where I think there's an opportunity, right? So we have a lot of data in our collaboratives. That's the whole point of having collaboratives, is that we can gather data, evaluate variation, identify high and low performers, and learn from that to come up with best practices. And certainly one of the things, as an example, that we've been doing in the Michigan Bariatric Surgery Collaborative. As far as data goes, so it started in 2006, and we have data on over 110,000 patients who have undergone bariatric surgery. So a lot of data on the perioperative care, preoperative comorbidities, postoperative complications, but there's a lot of patient-reported outcomes as well, and data on the hospitals and the surgeons who provide the service. We have amazing dashboards, so as surgeons and as programs, we can see where that variation is and where we rank along all of that. And certainly it's allowed us to promote a lot of initiatives over the years since we've been a very busy collaborative. And a lot of those initiatives have come to really involve improving quality by decreasing complications and thereby improving savings, decreasing costs. Now, one of the other effects of having a lot of data is using that data to inform our patients about their specific risks and benefits of any of the interventions that we offer. So we've been able to create this calculator using that data. And this calculator is a wealth of information that allows clinicians to, again, inform their patients, a variety of patients, their individualized outcomes with any kind of procedure that we do. And again, it's a lot of information, so they can learn about weight loss, they can learn about comorbidity resolution, they can look at the particular risks, compare the different procedures. And I think this has been a very important thing in the treatment of obesity and chronic conditions, is that shared decision making, and using data helps inform that. All right, so that only we only have that information for this bottom row of this chart, which is what we do in surgery. And quite honestly, surgery as an intervention is only utilized 1% of the time among all the patients who have or who suffer from obesity. So what about the other 99%? There's a lot to learn there about how to optimize any one of those treatment patterns and algorithms. So again, here, I think we have an opportunity. I think that opportunity can stem with partnering with other collaboratives that treat conditions with a lot of overlap with obesity. And so the obvious one there is type 2 diabetes. And this new type 2 diabetes collaborative, I think, can be instrumental in that. Part of what they're doing is also gathering data, creating dashboards, and understanding where best practices are so they can, evaluate performance and optimize it. And so this is an opportunity, regardless of which collaborative you're in, to identify sort of shared measures so you can use your collective knowledge to improve outcomes. We have a lot of data on the benefits or the outcomes of bariatric surgery on diabetes, both in comorbidity reduction and reduction in medication use. And so again, partnering with another collaborative, I think, is an opportunity there to take on a pretty challenging thing in the management of chronic conditions. And it really kind of brings us to the idea of individualizing treatment pathways to optimize outcomes, and not using the same thing or a variety of things where we don't know which outcome will be better. And I think this is where obesity medicine should be heading. This is what our patients deserve: a multidisciplinary, evidence-based, patient-centered style of care, much in the same way that we treat cancers nowadays. Right? We can't be comparing outcomes of metastatic cancer with solitary lesions, nor can we treat them in the same way. So obesity care, chronic care of conditions, has a way to go. And I think we're pretty well positioned to actually do something impactful in this space. All right, so challenge number 2. So obesity can cause and also worsen disparities in care. And that has an incredible effect of both the prevalence of the disease and our ability to combat it. So it's pretty well recognized that there's a strong association between poverty and obesity in the United States. Patients with poor access to healthy foods, resources, tend to have higher BMIs, higher comorbidities. But I'll argue that there's yet another layer of complexity within that. And that really stems to not a great way to actually measure obesity or its impact on health. So right now we use what the CDC uses, which is body mass index. You take your height and your weight, and we use that to make a lot of associations with mortality, comorbidities, and so forth. But it does fall short in a lot of different ways. And one of the ways is its accuracy overall. So it's not a great predictor of health, and it particularly loses its accuracy among men and the elderly, right? And it gets even more complicated with that. The severity of the disease doesn't always match up to the body mass index according to race either. This is another classic example of that. Asian Americans with a lower body mass index are going to have higher severity and higher likelihood of metabolic syndrome than non-Hispanic white folks, right? So again, the severity of disease is not well predicted by the body mass index alone when you're looking at diverse patient populations. And I think severity and chronicity of disease is a really important concept when you're trying to treat obesity and treat chronic diseases, right? Patients with higher severity, higher chronicity, metastatic disease are not going to have the same outcomes as patients with lower severity and lower chronicity of disease. So is BMI like the best way we can measure that? Well, I think it kind of falls short. Well, what are the other measures that we have? Age, we have sex, we have race. These are all the measures that we currently have available, and these are the ones that the CDC uses. But I'll argue that they still fall short for us to better understand disease process in general, the impact of our interventions, come up with solutions, and also measure success. Another important one there is also income. And again, a lot of these measures on their own fail to really give us any insight on the complex interplay between the biology and the environment, which we know is an important factor in the development of obesity and as well as its treatment. So the question is really, within our own communities, how do we identify what the at-risk population is, like the population with high severity and high chronicity of disease? And when we identify these at-risk populations, what are our current practice patterns in treating those folks? And are we seeing variation in outcomes with these current practice patterns? But identifying that at-risk patient population, I think is very helpful. And therein lies a really unique opportunity, which again, I think that we're really well positioned and we can leverage newer collaboratives like MShield. And MShield is a collaborative that has a really good foothold in understanding social determinants of health, which, as I've mentioned before, do play a role in obesity as well as its treatment. So, and it's not hard to picture this. I mean, things like food security, housing instability, access to care, these are their main focus of MShield. And I think, again, they overlap very well with obesity care and obesity management. So working with a collaborative that has that overlap, I think is unique and critical to having an impact. So one of the really great documents that they just come up with, which I'm sharing here, is sort of a toolkit on the ways to evaluate social determinants of health. And there are a few domains. And if you just kind of overview of those variables that they offer to evaluate and measure, let's say, economic status, there's a lot there that you can see relates and links to obesity and poor health. Health and healthcare status is also another big one. Clearly, patients who have, difficulty with activities of daily living, have poor diets, have poor access to healthcare, are going to suffer and have higher disease severity than those that don't. And I think, again, this is a great opportunity for our own collaboratives to identify this at-risk or high severity patient population and create an index. And using that information, identifying best practices, individualizing treatment pathways, again, to optimize our outcomes. All right, I'll leave you with this last challenge, or the last major issue in obesity, is that it's costly. And I thought I would throw this one in at the end because I am speaking to the Michigan Value Collaborative, and I think cost and value of care is incredibly important, especially when you're looking at population health, where costs are going to matter a lot. So what is the cost of obesity? Well, it's pretty staggering. It's pretty just mind-blowing. And these are numbers from the CDC in terms of total cost of obesity. It's 1.7 trillion. That's 34% higher for people with obesity. And you can see that healthcare coverage for most people is inadequate and insufficient when it comes to actually having access to a variety of those interventions, be it lifestyle changes, medication management, or surgery. Bottom left there, you can see only one state makes weight-based discrimination illegal. That means weight bias negatively impacts those affected financially, mentally, socially, and physically. So this idea of bias and stigma is very important to the care of obese patients, and only one state makes a weight-based discrimination illegal. And you know who that state is? Yay, it's Michigan. So go Michigan on that one. All right, so getting back to cost of care. So at this point, the idea is which intervention provides the best value, which intervention optimizes what the specific outcome that you're looking for, that you want to improve. And at the end of the day, which treatment pathway is the most effective? So it's going to be a multidisciplinary approach to treating obesity. What are the different pathways? What are the different options, and what are their different order, and over how much period of time is going to be the most effective for the patient, but also the most cost effective? That's a pretty tricky question to answer, but herein lies another opportunity with the Michigan Value Collaborative, of course, where we can actually have that type of information and integrate it in some of the analyses, where as clinicians, as doctors, as nurses, as providers, allows us to assess some of those interventions that we already know of. One of those that is near and dear to my heart, of course, is diabetes. Now, diabetes is a devastating disease, and it has staggering costs as well. And I think it's a little bit easier to tackle one specific disease process when it comes to evaluating cost than to just tackle obesity on its own, because again, it affects every organ system and results in a lot of different comorbid conditions. So look at these numbers. Living with diabetes, over $16,000 is the cost of living with diabetes, and over 9,000 of it is attributed to being diabetic. So that's 2.3 times higher than not having diabetes. So having the ability to move the needle and budge, the most effective treatments for diabetes can have a serious cost impact. And so what are the resources that we can implement in doing that? And one of the thoughts I had, of course, my bias is being a surgeon, that is the intervention that I know of. What is the value add of doing a surgery to treat diabetes, knowing that the cost of having diabetes is remarkably high, and that surgery as an intervention can be quite effective? So I did that exact project with the Michigan Value Collaborative, and it's been a pretty amazing find. We looked at patients who were diabetic and on medications before surgery, and we looked at the cost of reducing their prescription medications after surgery. And just at that 1 year, it had a cost savings of $4,000. If you look over the course of 5 years, if that patient remains non-diabetic over 5 years, it's more like $20,000. And if you look at all of our patients in Michigan who've already had surgery and had discontinuation of medication, it's up to $11 million. These are phenomenal numbers. And if you compare that to the cost of having bariatric surgery in Michigan, again, these are numbers that were provided by you all, price standardized 30-day payment, it's about $14,000. Now, it varies from procedure to procedure, but that's been the average. So you can see that after 5 years, there's a pretty good return on investment for a procedure to treat a medical disease. And this is very nicely put together by you guys. I think this is a phenomenal document. And I think it can have very important impact when you're looking at the regulatory space of treating obesity. And this was published in JAMA Surgery, which again is a pretty high impact place to demonstrate value in different interventions for different conditions. Just to orient you here, this blue bar indicates patients who have discontinued their medications. They're not on medications beforehand, afterwards. Now, these are all the variations of the medications beforehand. A lot of patients on oral medications, some on insulin, some on GLP-1s, which are a newer type of medications for diabetes. And you can see the cost go down, obviously, as medications get discontinued. So that's a great concept and a great sort of starting point of using different collaborative data, co-collaborating, and analyzing cost and value in the way we treat patients using certain paradigms. So I'll end with this newer concept of the idea of return on investment and how much do we invest in optimizing treatment, with the understanding that certainly obesity affects a lot of different organ systems, and there are a lot of comorbidities related to that. We also know that those comorbidities, when you add to any kind of surgery, orthopedic surgery, colon surgery, hysterectomy, hernia repair, that has a known higher risk of complications, and complications cost money. So our new thought experiment is, how do we optimize the treatment before getting orthopedic surgery, before getting colon surgery or hysterectomies? How do we optimize weight reduction and comorbidity reduction? And is the impact of surgery in that space before doing a non-bariatric surgery worth it? Is it going to reduce the number of complications to the point where that cost benefit differential is worth it? And so this is a newer concept, a different way to think about how to optimize obesity care before treating other conditions and before doing other procedures. And I'll end on that by thanking Kristen, Chelsea, and one of the medical students at University of Michigan, where we are actively and currently co-collaborating and looking at that very question. So thanks again for the opportunity to speak today. I tried to keep it down to about 30 minutes so that we can have an opportunity to discuss, ask questions, and so forth. Thank you.
Thank you so much, Dr. Varban. Wonderful. Does anyone have any questions for Dr. Varban about, what they're doing in the CQI, or anything that's going on at your sites that you'd like to discuss in relation to obesity and healthy weight management?
I have a question for you. Thanks for that presentation. So I did think it was very interesting how you were describing that surgery for the treatment of obesity is only about 1%. So with that in mind, what would you say are some of the barriers for accessing bariatric surgery?
Oh, what a wonderful question. Yes, it's certainly something that is a little bit mind-boggling. The most effective treatment for obesity is the one that's least used. And I have a few theories on that. First of all, the idea of surgery within medicine is still that of the treatment of last resort. So that paradigm is pretty pervasive. Like, you only do surgery when everything else doesn't work. And that trickles down all the way to essentially what our indications for surgery are, and how insurance allows or addresses where surgery is placed in terms of interventions and treatments. Now, I should say that all insurers cover bariatric surgery in the state of Michigan. So that's great. So that's wonderful. But there are barriers that are placed because of that paradigm. And that also extends out to referring physicians and primary care physicians and endocrinologists, folks that are not, that don't know as much or not as well educated about the impact of surgery, its effectiveness, its safety profile. And I think there's a lot of education that still is necessary there. So that's one aspect. I think it's also very difficult to broach the subject of treating obesity with surgery. I think there's also a patient aspect of that that can result in sort of its own barrier. In speaking with a lot of patients and essentially doing this for over a decade, I have heard a lot of the different sort of arguments for and against bariatric surgery. And when it comes from a patient standpoint, I think some patients still struggle with the identity of doing a procedure and that stigma that's out there of going the easy route, doing something, being associated with that my 600-pound life that they see on TV. And I think disassociating from that is difficult, because that in popular culture is a lot harder than what we try to describe to patients with like facts, science, and evidence. And, I think COVID was a good example of how difficult that can be. The other one that, and I'm going to put Anne on the spot because I see her there, which is so interesting in a project that we can work together with, is what is that decision making process among patients, and what is the impact of family on that? And so we're just trying to identify different barriers that we can actually address. And I think the education part of it, I think, is important, both from a provider standpoint, but I think this is the type of condition that you really have to go out to the people themselves and make them more aware. It's amazing the number of people that come in our clinic for surgery are self-referring. You know, some of the people, they don't want that their primary care physician know that they went that route, or they never heard it from their primary care physician. And I think that's an avenue that can be explored and should be explored.
I don't know, I just want to add a comment. This is Ann Cobom with the Ascension Bariatric Program. The insurances, when you talk about barriers, the insurance requirements and the processes are I think very preventative in many ways. And I do agree too that the primary cares, there is such a low referral rate, and we do get a lot of patients that, oh, my primary care doesn't want me to do this. And but that slide that you presented about the diabetes and the reduction in cost at just 1 year, I mean, that's pretty startling. And whether patients or those primary care or endocrinologists, I think that's a pretty eye-opening slide to share. And even insurance companies, that's something that I would think would interest them.
100% agree. Yeah, and thanks for that comment. I mean, it is pretty eye-opening, and in some ways, I think the different services that treat obesity aren't necessarily all aligned from an incentive standpoint, right? If I don't do surgery and I see a patient with diabetes, I'm incentivized to get the A1C down, treat with medications, not refer. I mean, that you work in your own space, right? So I think it's due time to, again, make it multidisciplinary, not work within silos. And yeah,
Very true.
And this is where, from a regulatory standpoint, this is where things like the Michigan Value Collaborative are really important, because at the end of the day, I think that's what insurance companies look at, is like, what is the return on investment, what is the cost or value add. And so being able to do these analyses, I think, again, makes us a much better position than other states to have an impact on that. I will say that there's been slow progress. And I'll give you a couple of examples of that. I think, and Anne, you probably are well aware, and everybody knows, even to get surgery, I mean, the indications are not that complicated. BMI over 40, BMI over 35 with weight-related comorbidities. The devil's always in the details. I've had patients denied, and I call and I do a peer-to-peer, and I said, well, their BMI is 38 and they have high blood pressure. They said, but they're only on one medication, so they have to have poorly controlled hypertension.
Yeah, I know.
Yeah, you remember that. So it's like, but it seems like, I mean, at least the last iteration, which is relatively recent, of the FASMBS, like the guidelines for use of bariatric surgery for the treatment of obesity, is starting to lower the BMI cutoff and those types of barriers or indications. And the American Diabetes Association has followed suit too. So that's promising. The other one, which was a killer, which I'm sure you also know about, Anne, is many patients were subjected to proving that they have attempted a medically supervised weight loss prior to considering surgery. And then this had to be proven before surgery would be covered, right? If it's not covered, they can't pay it out of pocket, right? So coverage means access. So in patients that had to go through medically supervised weight loss, they literally had to come to a clinic once a month And that was highly variable. Could be 3 months, could be 6 months, could be 12 months. And that varied based on insurance. The only things that the CDC, or sorry, the CDC wanted was, or the NIH, I'm sorry, in terms of guidelines, was that they've tried something else. But I would argue that you have to offer all options on the table up front and recognize which one is more effective in which avenue, much in the same way that we see cancer. I mean, we're not grading severity of obesity like we are with cancer, and a stage 1 is not the same way you treat a stage 4. And that's what we're doing with obesity nowadays. And I think that's why in many respects we're failing. Now, more recently, and this is just in the last couple of years, patients don't have to undergo like 6 or 12 months, by and large, of medically supervised weight loss. They can see us. It's amazing how many bariatric surgery programs are truly multidisciplinary. Everywhere, like, there are dietitians. It is a very multimodal approach to the treatment. It's not just surgery, it's surgery plus all these other factors. So that comes included when you go to a bariatric surgery program. And I think that's been more and more recognized. And in having that recognition, the idea of doing some medically supervised weight loss for however many months and documenting it appropriately has gone out the window. A really sad, I'll give you a story of an unfortunate sort of byproduct of this is there was a paper that showed that if your body mass index was above 50, then you didn't have to do that medically supervised weight loss because it's not going to help. Just do the surgery. You're at a higher severity, right? Surgery is for everything else has failed. Well, as it turns out, if your BMI is above 50, the likelihood of your BMI getting to 30 or below, healthier weight, is like 8%. The higher your BMI goes, the less likely you are to get back to a healthier BMI and have all those comorbidity reductions that improves your health. And sadly, the most important factor in getting to a lower BMI and having that improved health is your starting BMI at this time of surgery. So the more you wait, the worse it got. Again, we're inflicting disease severity on a patient by not addressing the care earlier. So it's a lack of earlier care. And the sad reality of that is that regulatory sort of subset of patients, if their BMI was above 50, then they didn't have to do this medically supervised weight loss. Well, true, in fact, primary care physicians, referring physicians, they wouldn't even refer until their BMI was 50 because they didn't want to do all of that stuff. So it's again, these regulatory things where it creates infrastructure of disparity and a lack of access that is truly unfortunate. Now, that BMI thing has gone out of the way, and I'm glad for that, but it took some time. And I know that personally, and I'm talking about it passionately because I wrote a lot of papers on that and said, you can't do this. And we wouldn't do it for any other disease.
Correct. And I think the other education aspect is in medical school and in educating physicians that it is truly a disease and should be treated as such in the same way that other diseases are treated.
I agree.
We have a question in the chat from Dr. Mansabar, but before we go to that, I just have a follow-up question to what we were just talking about. In regards to exacerbating the disparities among patients and the obese populations, what is your knowledge about, the spread of hospitals, institutions, organizations across the state who offer this type of surgery and care for patients in this cohort? Is there a high amount of access, or is it something that's more commonly referred out, to larger city hospitals and such?
Ooh, yeah, that's a great question. We have that data, so that wouldn't be hard to pull up and give you a heat map of where the volume of cases are. Just round numbers, there are about 40 programs in the state. There's about 80 surgeons. That's 7,500 cases a year. And I see Amanda on the line too. She may have some off the cuff knowledge of which programs have higher volumes than others. But I think it would be a great sort of analysis in Michigan to see, do our volume of patient populations match up with the volume of care in that location. I think that's kind of like the figure I see is like high volume of obesity there, small amount of treatment there. I'll tell you in I think it was a paper I reviewed. It was about a year ago. It was in Philadelphia, and basically they looked at urban areas and the volume of bariatric surgery there for patients that are at risk and also meet the criteria. And it was really good because there was an influx of more surgeons that were offering the treatment. So there is an association with that. Now, if you look at the numbers of like the prevalence of obesity, I don't think there's enough surgeons to do it all. It gives me a little bit of job security, but I'm sure, but I think matching where the disease process is worse with the amount of times where, or the prevalence of how we use the intervention, I think is another way to optimize the care.
Thank you. I appreciate that. I do want to address the question in the chat from Dr. Mansiftar. Besides the Obesity Summit, to your knowledge, is there any additional initiative planned to encourage the pediatric physician organizations to promote collaboration between primary care physicians, bariatric surgeons, and multiple disciplines in the comprehensive management of obesity?
That's all. Yeah, awesome. And I saw, and Amanda can speak to this as well, because that's certainly on our mind. And there is going to be another obesity summit, which I think will do very similar things. It was very successful last time. And the obesity summit, just as a summary, was a one-day event where different collaboratives came. So we got to learn about all the collaboratives. And we also spoke on the topic of obesity treatment. And this was very multidisciplinary, a lot of different, dietitians, psychologists, patient spoke, very informative. And I'll let Amanda announce, plans for the next one. And it also I think that also tied into the idea of maybe it shouldn't just be the Michigan Bariatric Surgery Collaborative. We should just like expand it and make it an obesity collaborative. I think that would be a fantastic idea because, again, all we know about is what happens to people who have surgery. That was the bottom, intervention. What about everybody else? Like, we don't have information now on different POs and their ability and their success or rate in decreasing their BMI of their population or decreasing the medication used for diabetes or improving their A1C. So being able to do that would be so valuable. And again, I saw Amanda unmute there, so I'm going to give her a chance to say a few words.
Hi, everyone. Yes, we are very excited. We just received approval from Blue Cross that we have begun working on putting together the 2024 Obesity Summit. In addition, we are working on, like Dr. Varban sort of alluded to, starting to think about MBSC, not just focusing on bariatric surgery. So we have a few things that are in the works that are up our sleeves, and that's sort of just a little teaser for fingers crossed. We hope will be some news we'll be sharing late spring, early summer about maybe the next steps of what MBSC, the work we're going to be doing in the coming years. So stay tuned.
Awesome, thanks. Yeah, it's in its kernel form now, but I think it's going to germinate and be great because you're right. I mean, we are striving for multidisciplinary care. So this will need to involve other services. It's also other perspectives, other ways to view how we take care of people.
I'm glad to hear there will be another obesity summit next year. I know it was a really successful initiative. I have a side question regarding, follow-up care to patients following bariatric surgery, if that's something you um, have significant experience with. Can you speak a little bit about the equality, equity, and access for patients to access resources, whether it's within the community or within the healthcare organizations, PCPs, et cetera, that they can continue managing their health and their weight following the surgery to prevent, readmissions or repeat surgeries, et cetera.
Ooh, yeah, no, it's a great one. There's a bit to unpack there. I'll start off by saying that as far as access goes to follow up with a bariatric surgery program, that's actually mandatory. All the programs that do surgery in Michigan, they need to be accredited, and they need to be accredited by the ASMBS. And part of that accreditation process is actually having having those resources in place. And one of them is, in fact, providing annual follow-up with patients. And practices that I've been in, that's what we do. We see patients at 1 year. It's a dietitian visit, and it's either a physician or a PA visit. That annual follow-up is just one component. I think it's important, but I think it's still very bare bones. And as far as, and certain programs I think do quite well in offering monthly, forget the name of it, but they expanded it into a Zoom. So it's like a monthly chat amongst patients. It's like a support group meetings. Certain programs provide a monthly sort of dietitian newsletter, which gives them information, a recipe, some new, vitamin. I think we do pretty well with patients. Now, whether patients like act on it, use it, is a little harder to measure. I will say, just in terms of 1 year follow-up with patient-reported outcomes, which is, so we ask within the Michigan Bariatric Surgery Collaborative, we ask our patients at 1 year to fill out a survey. That's critical for us understanding like long-term follow-up. And at 1 year, it's in the 70% range, right? So does that mean they fill out the survey, they didn't show up to their, to their visit? It's a little hard to tease that out. But, as we live in a more, I guess in a more modern era where people move and they don't necessarily follow up in the same place where they've had their surgery, I think we're going to have to start to think of more innovative ways of providing those resources to patients, using apps, using technology to follow up and keep track and make sure that the intervention that we did is actually effective 5 and 10 and 15 and 20 years later. There is great level 1 data to show that it is effective long-term, but a lot of that data comes from, honestly, places that have national health care, places like Sweden, where not a lot of people move and they have like over 95% follow-up rate at 10, 15 years. And so the data does exist to show that it's highly effective, but within our own communities, it's harder to tell. And I have this nice graph to show the, from a timing standpoint, where the intervention of surgery is in the course of a lifetime. And the front end of that is a lot of, it's not surgery. It's a lot of other touch points with healthcare. And then afterwards too, it turns into a bit of a black box. Now, volume aside, 1% of the population is getting surgery, but if you compound that 10, 15, 20 years, surgeon clinics are going to run out of space. We won't have enough space to see actually new patients. So I do think it's on another aspect of, effective multidisciplinary care, that the aftercare does move out to primary care physicians, internal medicine doctors, endocrinologists, people with a focused interest in obesity care, which, by the way, there is a fellowship for. There's an obesity fellowship, which is relatively new. So identifying where those spaces are and having care in that area, I think, is going to be the future of how to take care of post-bariatric surgery patients. And we see that concept in a lot of other things in surgery, like cardiothoracic surgeons are not seeing their, post-op patients 20 years later. They go to cardiology. Transplant, transplant surgeons do the surgery and then they go to transplant medicine that take care of all the medications and aftercare afterwards. So that in cancer care, the same. They see their oncologist after they have their surgery. So that does exist in other specialties. So there is a template for that. I think we can work on what that'll look like in Michigan.
Thank you. That's very insightful. And I'm glad to hear that there's a fellowship. That's new information to me.
It's often the Achilles heel of bariatric surgery, right? And we show how effective it is. We show how over the course of 10 years, I don't think there's any other procedure or surgery that has reduced its complication rate that quickly over that period of time. So we can prove all these benefits, but the question is always like, oh, what about 10 years? Are they going to regain all their weight? Well, some might not. What could we have done about it? We don't have answers to any of those right here and now. But we also don't have answers to, well, what if they didn't have surgery? What would they be like at 10 years? Like, we don't know, because we're not measuring that either. So I think that's the idea of combining both an intervention with, primary care, good follow-up over long periods of time. A question in the chat? Nope. Yeah, Amanda was pointing out a patient-facing app. I apologize, I didn't put that in the slides, but I'll share it. I'll share these slides and I'll share that additional slide at the end. So that risk calculator, the one I showed, is kind of more for physicians and providers. It's what we use in clinic. Pretty much many programs in Michigan will use that for every patient that comes in and said, these are the different procedures that we do. These are your potential weight loss and your, predicted weight loss and your potential risks as well, and complications and likelihood of discontinuation of medication. But there was one that was designed specifically for patients, so they get to learn about the procedures, learn about the different treatments, the different procedures that we do, but also they can plug in their own numbers. It uses the same risk calculator and then it spits out their own numbers for them. Again, I think that patient-facing aspect of it is really, really important for obesity care because that stigma still exists. And I think a lot of patients just have trouble bringing it up in clinic. And then, physicians may have trouble also bringing it up in clinic or may just not have enough time to. It's a long conversation. So if you give that power, that information, that data to the patient, they can do it on their own time by themselves and not have to face all those other questions.
Are there any other questions from the group today?
Hi, everyone. I'm Anne. I do social science research with the collaborative, and I just kind of wanted to point out that a lot of our qualitative studies have kind of shown the need for more support around mental health, both before the operation as well as after, because obviously kind of all of our relationship with food is at least somewhat emotional or psychological in nature. And a lot of, patients have kind of pointed out how happy they are with the surgeon and that particular team, but often, resources for mental health support just to kind of learn different coping mechanisms or to get at, maybe some of the trauma that kind of caused this relationship with food is one aspect that's kind of missing. And obviously one that's, much more difficult to address for lots of different reasons.
Yeah, thanks for that comment. I 100% agree. Yeah, and I think obesity also uncovers a lot of the issues that are in healthcare alone. I mean, access to care, ability to monitor long-term treatments, mental health. A lot of current resources don't go to that. So, if there is a proven benefit and value of care by adding mental health providers and dietitians into the healthcare workforce, then I think it's on us to prove that. and show it. I mean, we know it instinctively when we see patients, but we have to come up with the data to take the next step.
Final questions or comments? Okay, well, thank you so much, Dr. Varban, for your insightful presentation and sharing all of your wonderful knowledge with us. We really appreciate it, particularly with this month's theme.
Awesome. Well, thanks so much for having me.
Okay, well, I will close out today's work group. Thanks, Dr. Varban, and thank you all for taking the time to attend today and ask all of your wonderful questions. Again, this work group has been recorded and we will be sharing it with the registrants after the conclusion of the work group, and you are welcome to share it with any other members at your hospitals or physician organizations or institutions that may have missed today's work group. We also have upcoming events for chronic disease management, cardiac rehab, and health equity throughout the rest of the month and into February. You are welcome to register for them. We hope to see you there for those wonderful discussions. The registration link will be in the slides as well as found on our website. And with that in mind, thank you all again. I hope you have a wonderful rest of your day, and you are always welcome to send us questions to the Michigan Bariatric Collaborative email or any of us directly. And we can always connect you with Dr. Varban or any of other speakers at any time. So have a great rest of your day, everybody. Bye.